It's a great honor for us to be able to present this information and to give the people of British Columbia an idea of where we've been and where we're going with regards to the pandemic of COVID-19 here in BC. So I'm going to start with presenting what we call the epidemiology. So that is the person, place, and time of what has happened of our pandemic in British Columbia. This next slide, and I understand for those of you who want, there's a live streaming at the BC CDC website that will help you, that you can look at this as well. I know the last time we presented there were some challenges in being able to see the slides. But what this slide shows is what we call the epidemic curve. And that, for us in public health, is a depiction of what has happened in British Columbia with COVID-19. So the long, thick line on the top, the pink line, is what we call the new cases. So this is what we have been reporting every day in British Columbia, the number of new cases of COVID-19 that we've seen. And as you can tell, we've been at this for some time. Our first case in British Columbia was in January, and we had a number of imported cases over January and February. And then in early March, we started to see what we call community transmission. So it was importations that had then started to spread between others. And as we know, here in British Columbia, that often involved outbreaks at long-term care homes, with the first long-term care home outbreak in Lynn Valley in early January. What is also on this slide, down below, is the measures of our new cases in intensive care unit, and that's in the blue at the bottom, and that is a more stable measure of where we are now in this pandemic. It's the number of people who've required critical care in our system in BC. And also what we've plotted is the yellow line is the number of people who have died from COVID-19 in British Columbia. And of course, that tells us about the impact that this has had on our families and our communities. And we know in British Columbia, a lot of the people who have died are seniors and elders who've been in long-term care. The next slide is our epidemiologic profile. So that gives you an idea of who has been affected by this virus here in BC. This is the data up until April 14th, where we had 1,517 people who tested positive for the virus in British Columbia. The median age, and we use what's called the median, which is the most common, the middle age of people who are affected, rather than the average or the mean, because we know that there's been people who are very young and people who are very old who have been affected. And this gives more of an example of the people that are more likely to be infected in British Columbia, and the median age is about 54. And I'll show you some more data on age in a minute. We know that about 53% of the cases so far in British Columbia are female, are women, and this also reflects the fact that we have been testing in our healthcare system, and most of our healthcare workers are female. 349 people over the course of the pandemic in BC have been hospitalized, and we can see that the median age of those who have needed hospital care is about a decade older than those who have been affected. And this again reflects that most young healthy people have relatively mild illness that is being able to be, that they are able to care and stay at home and recover at home. The average or the median age of people who have been in hospital in BC has been 68. Currently, we have about 58 people, it's a little less than that today, in critical care or in our ICU system. We've had 942 people up until April 14th who have recovered. And so those are people who have recovered at home, have been discharged from hospital, have had their ICU care and recovered, and are now at home as well. We have some limited data on the underlying illnesses that people have, and about a third of people, a little over a third, have had at least one chronic condition, and those numbers go up as we get older, and we have more likely to have illnesses like cancer or diabetes or other things that make you more likely to have more severe illness. As of the 14th, we had 72 people in British Columbia who died from COVID-19. And the median age of those who died, again, is quite a bit older. So we know that it more differentially affects our seniors and elders, and we know that the long-term care facility outbreaks has led to a large number of people who have died from this disease, and their families and their caregivers have all been affected by that. The next slide talks about where geographically we have seen cases, and what you can see is that no region of this province has been spared. We know that there have been outbreaks and there have been cases, there have been imported cases, there's been community transmission in all areas of the province. Having said that, the bulk of the cases are in the Lower Mainland, in the Vancouver Coastal and Fraser Health regions. On the next slide, this gives you an indication of the percentage of our population in different age groups that have been affected by COVID-19 in British Columbia. So the bars on the far right, the pink bars, are the proportion of people in that age group in our population in British Columbia. So we have about a little under 10% of our population is under the age of 10. About 10% are in the 10 to 19 age group. And you can go along and see that. So we have a very small percentage who are over 90. But when we look at the number of people who've been affected by COVID-19, so that's the green bars, that are the second bar in from the right, most of the cases have been people between the ages of 30 and 60. And again, that reflects that we've been doing a lot of testing of our healthcare workers and other essential workers who tend to be in that age group. Those who've required hospitalization, the next bar over, again starts to skew towards the older age group, the older population. And that continues for those who need intensive care. So those are the yellow bars, or green bars, depending on which of the graphs you're looking at, the next one over. Most of those people who have been required intensive care and ventilation are people in the 50 to 79 year age group. And finally, the bars on the far right are the deaths that we've had in BC from COVID-19. And we've had one death in a person in their 40s, two people in their 60s, but the majority of them have been people who have been in their 70s, 80s, and 90s, including somebody who was over 100. So this again reflects the tragedy that has been the outbreaks that we've had in our long-term care homes here in British Columbia. In the next slide, this is a little bit more detail around the epidemic curve and what it's telling us about the progression of the pandemic here in British Columbia. So this is the cases reported by the date that their laboratory test came back positive. So this is the information that we've been presenting to you on a daily basis, the new cases that test positive in BC. And what I've put on this slide is also two lines that show when our testing strategy changed. And you will recall that earlier on in March, we started seeing more community transmission and outbreaks in care facilities, and we focused our testing on making sure we were understanding what was happening in our community, picking up outbreaks, and protecting our health system so that we were able to care for everybody who had COVID-19 as well as those who needed care in our system. And the gray hashed area, the gray shaded area, reflects the time that we put in public health measures. So that's when we started to put in those measures that put distance between us as a way to stop the transmission of this virus in our community and in our families. And so that was when we put in the travel restrictions. We put in the social distancing measures. We put in place the suspension of in-classroom schools, the closing of certain businesses where people gather together. And what you can see from this is that that occurred over a period of time, and we still saw cases, quite high levels of cases, over the next number of days. And you may recall my saying that what we were seeing at that time reflected exposures that had happened during the incubation period, so up to 2 weeks prior to that date. And once we got to the 2 weeks from when we put those measures in place, we start to see a gradual decline in the number of new cases. That's our bending the curve. The second line that I put in on April 9th is when we, last week, when we said that now is our time, we have capacity in our system and to be able to start broadening our testing again to make sure that we aren't missing cases and outbreaks and clusters in our community. On our next slide, this is the same graph but presented by the date of onset of illness. So what I have talked about over the last weeks and months has been the work that we do in public health to understand each and every case of this disease. And that means looking at when people's symptoms started. And it is helpful for us to put that on the graph because it helps us understand where and when exposures happened. It also is part of the reflection that we have around contact tracing. So when I know when you started having your symptoms and I know who you've been in contact with, I can isolate those people and make sure that they're not passing it on to anybody else if and when they get sick. So that's what this graph is showing, and I've put in the two lines around the laboratory testing strategy so you can equate it to when the test results came back. And what we can see quite clearly is that when we put in these public health measures, we started quite quickly to see a decrease in new cases coming out in British Columbia. The other thing that's reflected on this is where people acquired their illness, for the most part. We don't know for some people, but for most people we're able to plot it. And the bars on the bottom, the dark ones, the blue, that is people who acquired their illness outside of Canada, so from travel. So those are the travel-related cases, and as you can see early on, that's mostly what we had, with some limited transmission, mostly within family units. And then we started to get quite a bit more early on in March, and a lot of that was reflection of travel from the United States, particularly Washington State, when we became aware of the extent of community transmission in Washington. But we continue to see imported cases of disease, and those are ones that we're monitoring very carefully. And one of the reasons why we put in the measures that we did at the borders here in British Columbia and now across Canada to make sure that everybody who comes home to BC is able to join our efforts to make sure we're stopping the transmission of this virus. And that means making sure they have a plan and we can support them in self-isolating so that if they do become ill, they're not going to transmit it to their family or their community here in BC. So the next 4 slides are a presentation, the next 4 slides are showing the graphs of the trajectories that we presented before with the updated data from here in BC. So, and some updated data, of course, from the other jurisdictions that we compared ourselves to a few weeks ago when we presented this. So the first one is the cumulative diagnosed cases in British Columbia compared to a number of international, a number of other international outbreaks. And what this is a rate. So it is the number of cases per million population. And we pulled everybody back because we know things were timed at different times around the world. But we pulled everybody back to day 1 is when you reached 2 cases per million population. And the reason why BC is a little bit farther out than the rest of Canada is because we hit that marker first. We had the cases that we had here in BC started earlier, and our pandemic started earlier than other parts of Canada. But as you can see, we have flattened that curve. And compared to Canada, we are still at a fairly low but steady rate, and we are much lower than what we see for the United States, for Italy, for Spain, for some of the other countries that have had outbreaks that have followed us in their trajectory. The next slide presents the same information comparing us to other international outbreaks with the rate of deaths that we're seeing in British Columbia. And I know it's a challenging thing because everybody's outbreak is somewhat different, and ours, of course, has been driven by the tragedy of the deaths in our long-term care homes. But this looks at a rate, so deaths per million population, and it compares where we are in BC with the other jurisdictions around the world. And the challenging thing that we need to recognize is that we are at the point in our outbreak where there are still people in hospital, there are still people very ill with this disease, and it takes some time, weeks, up to 6 weeks, we know from around the world, before somebody will either recover or may succumb to this disease. So it is, unfortunately, the truth that we are going to see more people die from this disease in the coming weeks here in BC. The next slide is the same information, but presented BC relative to our other jurisdictions here in Canada. And I will note that the scale on the left-hand side is not as high as the international one. So we're not comparing Quebec, for example, to Italy. This is a reduced scale, reflecting the fact that we have not seen such tremendous increases in Canada that they have seen in some other countries. But we can see again that BC is out front in terms of time, because we had our cases started earlier here in British Columbia, but that we have flattened and leveled over the last few weeks. And again, this is the same presentation of those rates of deaths in British Columbia over the past number of weeks. And again, it has unfortunately increased, but has leveled off, and we're starting to see that now in Quebec and Ontario as well. So that is the epidemiology. That's bringing you up to date with some of the modeling that we did earlier to see the trajectory of our pandemic here in BC. And I'm now going to turn it to Minister Dix to talk about some of our operational planning.
Thank you very much, Dr. Henry. And I wanted to turn to page 15. This graph will be familiar to everyone from our presentation of March 27th. What we did at that time was to follow or extrapolate from the situation in Italy, in Hubei, and in South Korea. What if we had followed, or we were to follow those trajectories, what the epidemic would look like in British Columbia. And so you see this data, you see that Italy was the most serious situation at the time. It had not begun to level off at that time. You see the trajectory in Hubei province. You see the trajectory in South Korea. And the intent of this was to be prepared for the worst. And as you know, we've taken a series of steps since that time, at that time, and since that time to prepare for that. So that you've seen before. I want to move to chart number 16. This tells us what actually has happened since that time. You see, we know more about the epidemic in Italy, and that goes forward. We see that Hubei, which had already leveled off at the time of March 27th, and of South Korea, and you see on the line what's happened in British Columbia. In other words, we are much closer on the cases here, because these are the model cases in BC, much closer to South Korea than we were even to Hubei at that time. On slide 17 as well, we presented this on March 27th when we presented the modeling at that time. Again, you'll see there's one difference between this and the previous chart. We did two models for Italy. There had been a lot of discussion at that time, including in medical circles, and concern about the Italian situation, which was quite natural. So you have two models here for Italy, one in the blue based on cases, and one on top based on the highest one based on hospitalization. So you see what that said. And this was the preparation that we would need to make, and we needed to make to prepare should those trajectories in Hubei, in Italy, become a reality in British Columbia. So that was what we presented March 27th. And now on page 18, you'll see what has happened since then. On page 18, you'll see British Columbia is in between Hubei and South Korea in terms of critical care cases, which is one of the ways that we measure this, and obviously the most important ways for people working in acute care hospitals. And so you see the trajectory of critical cases in British Columbia. You'll know a little over a week ago that peaked at about 72 cases. It's now at around 55. But you'll see that we are well under Hubei, of course, dramatically under what happened in Italy, although a little above South Korea. I want to give enormous credit to our critical care teams who were involved in the development of our strategy. They've done a number of things, including early venting, including providing oxygen earlier than had been done in other places. And so our numbers are slightly higher than they would otherwise be because of the extraordinary work of our teams. And you see that in the results of people who've gone into hospital in BC. So what are the key findings of these things? The key findings are that we're well below the projections based on the Italian and Hubei experiences, that BC COVID-19 cases have plateaued and started to decline in terms of hospitalization and in terms of critical care. And for example, hospitalizations a little over a week ago peaked at about 149 and is at 120 now. The most important fact of that is that it peaked at 149, well below, well within our capacity to deal with it. Similarly, that BC's COVID-19 ICU census curve has remained well below the Hubei and Italian experience. This too appears to be plateauing, and we have cautious optimism about a downward trend, but only cautious optimism. Deaths, of course, continue to be particularly profound amongst those who are elderly and frail, and Dr. Henry talked about long-term care. So given these findings, you're not going to see, when we provide future modeling, the Hubei and Italian models anymore, because as reference points for BC, they're now less important. The new models are going to be based on our experience in BC, and understanding of the virus will guide us as we go forward. I just wanted to talk briefly, and before I turn it back to Dr. Henry, about the health system level of preparedness for those who are critically ill. Over the past weeks, and we've described it, Dr. Henry and I have described this in our daily briefings, as have people from the health authorities. The health authorities have prepared across BC for ill and critically ill patients. They've created capacity through decanting patients, finding access and supports for patients who do not absolutely need to be in the hospital, and of course, by the actions we've taken with respect to elective procedures and surgeries. Critical care capacity has been prepared and added in each health authority through the creation of 19 COVID-19 sites throughout BC, and you'll know additional sites have been created at the Convention Centre at Royal Columbian Hospital, for example. Each primary COVID-19 site has specifically planned their space, their workforce, and their supplies, including ventilator capacity, to address a surge based on the models that we presented to you on March 27th. On page 22, you'll see some of the results of that in terms of bed capacity, that our total critical care beds with surge capacity, the surge capacity we added, which is, you'll remember, included cardiac care units, recovery rooms, operating room capacity, and the reconfiguration of units, has increased significantly to 951. And you'll see here in the next two columns the census data that we have. This is based on the April 13-14 data, which was 58 critical care COVID-19 cases of 58. And there's also, of course, non-COVID-19 census of critical care, which is at 377. I'll note that there's a small error, I think, on Fraser Health here. That should be 209 to come down to add up to 516. The overall critical care capacity of the province, occupancy rate, I should say, the total vacant critical care beds are 516, and therefore the occupancy rate is 45.7% in critical care. These are the numbers, the detail of the numbers that we've been reporting to you every day for the last number of weeks. They show that we have prepared for this. I would note that some of that critical care capacity, should we return at some point, as we expect to providing elective surgeries, will be taken up by that. And that's an important consideration as we consider the coming weeks and months. I want to move on to page 23, which talks about our ventilator capacity, and we can certainly answer questions of this in detail. You'll note that that we had originally identified 457 adult critical care ventilators. There are, of course, there were at the time 1,272 total ventilators in the province, but these were the primary ones we would use to address issues around COVID-19. Since then, we've made significant additions. We've moved as you can see in column 1, a number of the new ventilators we've obtained and the refurbished ones we've obtained into the Interior Health Authority and the Northern Health Authority. We have a number of ventilators that are not assigned at present, and we've added considerably to our ventilator capacity. That capacity is now gone from 457 at the beginning of March to 681 now. And the next slide, page 24, will show how we've been using that capacity. We haven't provided, I don't think, these numbers in the daily briefing, but you'll see this is the number of ventilators that are in use in critical care. The numbers along the bottom you'll see are the ones being used for COVID-19 patients at present, and that number as of the 14th of April was 38, having peaked at 55. And the number on the top is the total mechanical ventilators in use for all purposes, for all patients in British Columbia. And so you can see again that our preparations, that our needs at the moment are well under the preparations we've made. That said, we have to continue to make preparations in the coming months for our healthcare system, as in advance of this fall, for example, in advance of the possibility of further surges in infection from COVID-19, and we intend to continue to do so. So what are the key findings? That we've carefully reviewed and articulated specific available critical care beds as well as potential surge beds in other spaces within sites. Surge beds identified surpass even the demands of the Italian modeled curves if they had occurred, which they did not. Additionally, additional adult capable critical care ventilators have been identified, purchased, and loaned, and 681 would surpass numbers required for even the Italian modeled curves. Critical care capacity in BC and thus far in the epidemic has been sufficient. As you know, we have many thousands empty beds at the moment. As a province as a whole, critical care capacity just in the ICU and the high acuity units, not counting the additional surge capacity we had, has been at 70% over this period. And of course, I would say, and this is the time to just briefly mention that obviously, for all those people who have been waiting for non-urgent elective surgeries, these are critical things that we're looking at in the coming weeks and months. We are developing, under the direction of the former president of the Fraser Health Authority, Michael Marchbank, a plan at some point in the future to resume elective surgeries. We believe that will be in May, and we will have more details about that plan as it comes forward. But as you can see, that planning has to take into account the circumstances that we've described here, because we'd be moving beds that are currently right now surplus to our needs for COVID-19 back to support elective surgeries. And so that is will be a very challenging plan to put together, one that will require working with surgeons and many others in the system as we plan to implement it, and we'll brief you in full as we develop that plan in the coming days and weeks. So with that, I want to return it to Dr. Henry to talk about the effect of our public health measures, how they have succeeded, and what has succeeded.
Let me just catch up here. Okay, so this is the important part around. We've shown you where we've been, where we've come to. Now's our thinking about where do we go from here. This again is the timeline that I presented earlier. It has on it marked some of the key milestones of the timings when we put in place certain measures. And what it shows again is that we have had a decrease. We've had a decrease in new cases, even though we have expanded testing once again. This next slide is a really interesting one. It's some of the modeling that we've been doing at the BC CDC and with UBC and Simon Fraser working with us on this. And it compares where we were in British Columbia at the time that we put in some of these public health measures. And it uses what we call a stringency index I would not have come up with that term myself. However, this was developed at Oxford, and it's a way of comparing the measures that have been put in place in jurisdictions around the world and comparing how strong they were in forcing or requiring physical distancing and other measures that kept people from being able to transmit this virus in our communities. And what we look at, if we look at BC, across the right-hand side, the line that you see that's kind of in orange, that's the trajectory that we presented in one of the slides earlier. So that's our cases per million over time. And the blue dots reflect the public health measures that we put in place. So things like the social distancing, things like the closing of schools, the closing of restaurants, the orders around travel, around mass gatherings. And as you can see from the dots, we actually put those in place rather rapidly within a short period of time, and our stringency was quite high. It was up about 80% on this scale. And we did that at a time that was relatively early on in our increase in numbers of cases. So that, I think, is one of the things that kept us in good stead, that allowed us, because people adhered to these actions, allowed us to bend our curve. And if we compare to Canada, which is up on the right-hand side, they took very stringent measures as well in provinces across Canada, and this is particularly Ontario and Quebec. And the stringency was slightly lower, but about as high as we did. But it took over time, and it also happened at a different point in the exponential growth of the outbreak in those provinces. And we learned from that. And we put in our measures at the same time as Quebec did, for example. But we learned from our colleagues in Quebec because their March break happened to be prior to ours. And in our discussions across the province, they started to recognize that there were people coming back, particularly from travel to France, and that they were becoming sick and spreading it in the community in Quebec. And we took advantage of the experience that they were having to be able to put the measures that we needed in place early in BC. If we look at Italy, which is directly below BC on this graph, again, they put in very stringent measures in Italy, but it was at a time where they had already started to see exponential growth in cases in the community. So there's a couple of things that this tells me. One is our early testing strategy, where we did a lot of testing in our community, helped us to better understand where transmissions were happening. So we did have a good sense of where we were at the time when we started to see community transmission and an increase in the cases that we were seeing in BC. And we also learned from what others were doing around the world. On the next slide, this is a measure of how people in BC have reacted to the public health measures that we have asked about. And it is a partnership that the BC CDC has had with Google to look at where people have been moving in BC. And it's quite a busy slide, but what it shows is that since we put in place those public health measures that we're talking about, the safe distancing, the closing of schools, the working from home, the staying at home message, people in BC did follow that message. And we saw a dramatic decrease in people moving to workplaces, to transit, to retail and recreation facilities, and even to groceries and pharmacies. And we saw an increase in people staying near home. The green bars that go up and down at the top, those are visits to parks. And this has been an important part of our strategy, is that it is important, we believe, for mental and social health, for people to be able to go outside, but to do it safely and to maintain those safe distances when they are outside. So this is the summary of our current state. And now I want to talk a little bit about, what does that mean for now? What does that mean for going forward? So we are, our actual case rate and our actual ICU admission and hospital admissions have been below what was potential based on the experience of other jurisdictions around the world. We are experiencing a slowing of our rate of new infections, and we want that to continue. We need that to continue for us to be able to move to the next stage. The difference between what could have been and what actually happened here in BC is because of the measures that we as people in BC took together, each of us individually and collectively. The social distancing, the social connectedness, the physical distancing that we took. The fact that we took it to heart that we needed to stay home and stay with our families and our households. The fact that we took it to heart to clean our hands, to make sure that we were cleaning our environment, to make sure that we stayed away from others if we were sick ourselves. Those were the things that have allowed us to bend that curve here in BC. This slowdown is due to our public health actions. It's not due to what we call in epidemiology herd immunity, or what I prefer to call community immunity, which occurs in one of two ways, and we've talked about this before. One is if a large number of people become infected and survive, and therefore have immunity going forward. And the other, of course, is when we have a vaccine that's able to protect people in our community. So we do not have enough people who have been infected, which is a good thing in our community, to have herd immunity from infection. And we don't want that, because we know that even in those areas like Italy, like Hubei, where they've had explosive outbreaks in the community, even then only a small proportion of the community actually has immunity over time. What we really need is a vaccine, and it's going to be some time before we get a vaccine. So how do we manage that time in between? Our goal, as we move forward, is to control the transmission and growth of any new cases of COVID-19 in our community, and minimizing any of the negative unintended consequences of these public health measures that we've put in place. And so that is our dilemma, and what we need to focus on for the coming weeks and months is just the right amount of restriction so that we don't end up having those explosive growth, so we don't end up overwhelming our healthcare system and our critical care system, and we are still able to start moving to get our healthcare system moving again and to get our society moving again. So how are we going to do that? We have a number of tools that we have been developing over time and that we will be using and are using to help guide our policies and our plans and strategies for moving forward. We have epidemiologists across BC who have been working on this, and again, I thank them. There are several different types of models. One is a forecasting model that can predict new cases and help us understand the impacts if we do certain things. And the other are what we call dynamic models, and they sound simple, but they're quite complicated, and they take into account our demographics, the way we move and interact with each other in our communities, and we're using those as well to help us understand. And these are tools that will support us in the work that we've been doing and will continue to do about how we can safely and thoughtfully reopen our society and reopen business and our healthcare system. I will caution, though, it is not going to be the same. We are not going back to, right now, what we had in December. It's not going to be the same. Our new normal for the coming months, and it may be some time, is going to be modifications of what we're seeing right now. This is an example of one of the models that we're using to help guide what we're looking at for our future. And it is one of what this says to me, it reinforces our need to stay the course for now. When we look at where we are, those yellow bars give you an example. This is looking at critical care. So it's one of the models. It's not the only one, but it looks at where we are now and where we need to be. And the lines on this look at the restrictions that we've put in place, the public health restrictions that we've just talked about. And as you can see, the red line that goes dramatically up very soon, that's if we take everything away and start going back to what we thought was normal in December. And that is what we want to, and need to avoid. All of the sacrifices that we have been making across BC for the last month and even longer will be for naught if we don't continue to take those measures now and thoughtfully and carefully open up as we are able to, and to make sure that we are monitoring carefully across the communities, across BC, to make sure that we don't end up having a surge that overwhelms our system in the coming weeks. So we are on the right track, but we must hold that line. Together we have made good decisions, and we've made them at the right time, and people in BC have done the work that we need to do. Like we have done already, we are going to develop an evidence-based and thoughtful plan for our way forward. It is essential that everybody in BC continue to practice what we have been doing, our physical distancing, for the near future. We have had success in BC by being diligent and being thoughtful and working together and supporting each other to get through this. And we need to continue that. And, you know, this is not the end for us. It's not even the beginning of the end. And to quote Churchill, it is perhaps, maybe, the end of the beginning, but it is a thoughtful process that we need to continue for the coming weeks and months. And I'm going to leave it at that and say thank you